So with that, we will get started. I'll allow Dr. Jenkinson to share his screen, and he will present the first case, which I think will allow us to get an excellent start into this with something maybe you could think of as a more basic injury type pattern, but I think it will bring home some very interesting discussion and some points. So Richard?
Great, so my screen's being shared okay?
Yep, looks great.
Perfect. Well, good morning, everyone. So as Dr. Sims just said, this is a good bread and butter kind of case that anybody treating any volume of pelvic fractures is going to see with some regularity. So some things that we want to look at today is a few of these learning points about roles of binders, how to deal with some initial hemodynamic instability. We'll look at the images and how we go through this case in terms of deciding on fixation and post-op. So this is a case of a 58-year-old man. He's a hay farmer, previously healthy, elevated BMI. And this is my case from Toronto. So there are a few cowboys around, not just Dr. Rout's neck of the woods. He's riding on his horse on a farm, and the horse is spooked and he's bucked off. He presents to the trauma bay. He's awake and responsive. He's fine from an airway and breathing perspective. His circulation is abnormal. He's got a high heart rate and a blood pressure that's lower than expected. His FAST is negative, and this is his initial pelvic x-ray. So just take a second and look at that and think about what might be the problem and how you would deal with this. So when I look at this, it's quite obvious the anterior ring is disrupted through the symphysis. There's quite a bit of diastasis, several centimeters. And if you look at the posterior ring, the SI joint, particularly on the left, is disrupted, and the right one might not look normal either. So what are we going to do at this stage for a patient who's hemodynamically unstable with a pelvic ring, which seems to be the main culprit? So as we learned in the talks, the next step is probably going to be something to help with volume control. So the main options for that are the sheeting technique, which we saw in the lectures, and then a pelvic binder. These are a couple of the commercial pelvic binders, which are being used very regularly now. And just a point on how these are applied. So it's quite important to remember that the greater trochanters are the position where they need to be centered. So the green arrow is pointing to where the binder is basically pushing on the hips to collapse the pelvis back to a normal volume via the hip joints. And it shouldn't be centered on the iliac wings because that will be ineffective and also tend to slip up and around to the patient's abdomen and not be very effective. So don't do that. So this is the patient after he's in a binder. So you can take a second there. You can see the binder artifact on the x-ray. And we can see the patient's closed down quite a bit. So at this stage, you've got to think, if this patient has not been fully resuscitated, if they haven't responded, what would be some options to manage that? So probably the binder could be retightened and improve the reduction. In terms of other things, in the past, in some places, maybe even still, an acute external fixator is considered. I'd say in most jurisdictions, a separate trip to the operating room to apply an external fixator is not in most people's resuscitation algorithms anymore. I'd say that's something that's not done in most jurisdictions. If the patient's going to the operating room for some other reason, then that could be consideration. And as we learned the other day, a resuscitation screw to close down the posterior ring may be appropriate if the situation's right in terms of the patient, the surgeon, and on the team factors. So this is the inlet-outlet views for this patient. So you can take a second to look at those and evaluate the injury again. You can see the pelvic ring is, as I've mentioned, not fully closed down. The left SI joint, I think you can see very well on the outlet view, is clearly widened compared to the other side, which looks pretty close to normal on the right. And the inlet view confirms that as well. So the next step would be to get a CT scan. So as I mentioned, the patient responds to the binder and the blood transfusion. So despite not being fully closed down, the patient hemodynamically stabilized after this initial reduction maneuver. So here's the CT scan. So we can take a look at this and evaluate as we go through. I think we'd agree that the pelvic reduction looks quite excellent in the CT scanner. A little bit of an increase in the left SI joint in terms of not being completely normal. And now we're getting to the symphysis. And I don't know what you people think, but from my perspective, the symphysis looks quite a bit better in the CT scanner than it did on those, even the initial bound X-rays. So here's a few sort of isolated cuts. You can see the SI joint. Another thing to notice is this patient has quite favorable anatomy for iliosacral screws. He's a large patient, and he also has large corridors at S1 and S2. Perhaps there's a little vacuum phenomenon in the right SI joint, just to be aware of. Maybe there's something more there than the CT scan would suggest. Here's a 2D recon. And here's a scout view when he was in the CT scanner. And I think we'd agree that this looks quite a bit better in terms of reduction than the plain films I showed you a few seconds ago. And this is something that's been noticed by some of our faculty. Dr. Riley and his colleagues wrote this up, showing how just the act of placing the patient in the CT scanner, having them positioned for that, it tends to reduce many people's pelvic rings, especially when they have a rotationally unstable injury through the symphysis such as this. And you have to be careful because some might actually reduce to the point where you're not as worried about them being unstable. So if you were to look at just the CT scout image and didn't have the benefit of the previous injury films, you might be even thinking this patient might have an APC1 injury, when I think it's quite clear he has at least an APC2, and some people may even consider it an APC3 based on his first films. So how are we going to treat this patient? We know that he's got at least the APC2 injury. So we know the front needs to be fixed. So here's some intraoperative X-rays showing the pelvic plate going on the symphysis, a retractor holding the bladder back, a little K-wire and a clamp holding the reduction. And this is the plate I tend to use, which is a specialty pelvic plate, which is built up in the middle and a bit more bulky than a standard pelvic recon plate. The advantage of this plate is it's nice and heavy, has a tendency not to break. One problem though is it's hard to mold to the pubic tubercles, so it pretty much has to sit a little more posterior than maybe optimal if you're going to try to get those long screws down the inferior ramus. So some of the faculty prefer a more malleable plate, but my experience with that is sometimes it breaks in the middle, and I don't like to see the plates break, so I tend to use the bigger one personally. So we fixed the front. It looks pretty reasonable. And now we have to decide if this patient needs more fixation. So, we classify this as an APC2, and many people would consider this to be enough. We could finish the operation at this stage. It's become, clear in my experience, and then also some papers suggest that the pelvic ring acts as a unit, and if you fix one side, you're going to improve the biomechanics significantly by fixing the posterior part as well as the anterior part. A little bit like fixing a bimalleolar ankle fracture. It makes sense to fix both sides of it. So we can, this has been observed in a paper fairly recently, where they looked at a lot of their APC2 injuries. There were 134, and there was a much higher rate of fixation failure with the anterior only fixation than they did with even a single SI screw at the back. And the malunion rate was also higher with only anterior fixation. Obviously there's some selection bias. It's particular surgeons have particular patterns in this, but still I think this is valuable information suggesting that posterior fixation is something that should be strongly considered for many of these APC2 injuries. And just a quick word on anterior plating. Usually that superior plate is enough. There's a history of double plating symphysis, and in my experience, the bone from the front to back for that anterior plate is pretty unsatisfying. And in my opinion, a single plate with posterior fixation is the optimal fixation construct for most things. And certainly 2 plates and no posterior fixation doesn't add enough to really be a worthwhile endeavor. So this is evaluating the SI joints for this patient. It looks like the The left side's reduced quite nicely. The right one I don't have pictures of, but it certainly reduced. So we put in 2 SI screws to support it. They were put in this order with the SI-oriented one to sort of help lock in whatever gap there might be to try to improve the closure of the SI joint, and then neutralizing that with a second transiliac transsacral screw. And again, is that necessary? There's a lot of suggestion that maybe 1 screw would be enough, but the patient with nice favorable anatomy made sense to me to make a stronger construct for him. Also quite a large gentleman, and I never quite trust the anterior plates when the patient's obese. So this is final images, and satisfied with that reduction. So then now what to do post-operatively. So there's not much science on this. In my experience, if you have a tile C fracture, they can be quite disastrous if they fail, and I want to be careful with that. So I prefer to keep the tile C fractures non-weight bearing. The tile B fractures, again, it's a bit of a dependency on the patient factors. Is the patient going to be compliant? Are they large? Is their bone fixation good? Is the fracture a bit more inherently stable or not? But usually I'll let them do some sort of protected weight bearing with crutches or a walker. This patient was a farmer and still is, and asked me when he could get back on his tractor. So that makes me a little bit more worried he's going to be less compliant. So I definitely asked for him to be 50% weight bearing on that left side, and weight bearing is tolerated on the right. This is a similar case, just to show some follow-up of something like that. This is one I did in the past where we just fixed the front and didn't fix the back. And he did okay, but he went on to lose some fixation after a few months. Not enough to need revision surgery, but certainly it could have gone on to failure, and a certain number of patients with that injury and no posterior fixation might fail enough to need a revision. So I think my practice has evolved where I routinely put in posterior fixation for any of these APC injuries, and very rarely do not put that in, really only if there's very unfavorable anatomy for iliosacral screws. And you can see that bit of opening. So hopefully we cover these. So remember, the pelvic binder is a good first option for closing down the patient's pelvic ring. It should be centered at the greater trochanters. In terms of acute external fixation, so we talked briefly about iliosacral screws as a resuscitation screw. Another thing that could be considered is if this patient was a different scenario and went to the OR for say a laparotomy, if the situation is right, it's quite reasonable to go ahead with symphyseal plating if that's something you're comfortable with and the patient is in a reasonable situation. Certainly, for me, I can put an anterior plate on at about the same amount of time as an external fixator, and will be good for him long term. We looked at our images, and remember the inadvertent reduction during CT. Keep that in mind. You may need to have an examination under anesthesia or take post-operative plain or post-CT plain films to really be able to assess that patient to understand whether they will need surgery or not. And then posterior fixation is definitely preferred in almost all of these patients, in my opinion. So that's great. Hopefully that's been helpful for you.
Hey, thank you, Richard. That's a good case to get things warmed up and started with, while Dr. Stover is getting his case ready to roll. And you can go ahead and stop sharing yours, Richard, and we'll get Michael to share his screen. I'll just ask you one question while we're going to the next thing. Is there any role for definitive treatment of a symphysis dislocation with an external fixator in your practice?
Very limited. The stability you get from an external fixator is quite poor. So in almost all cases, I think the symphyseal plating is preferred. There may be some particular situations where patients had a bladder rupture and extreme infection, and you really don't want to be putting a fixation in. But in most cases, even with urologic injury, with a repaired bladder and a cleaned out symphyseal region, I prefer to put in a plate. And that sort of last case, the one with just the symphyseal plate, that was the actual situation for that patient, where we washed out and repaired a bladder injury and then plated the front. And that was an acute sort of emergency operation. And at that stage in my career, I wasn't quite ready to put in SI screws, and we just sort of didn't get around to it. But I think it's something I would do now.
Great. Thank you very much, Richard. There are a lot of good questions that came through. Some of them have been answered. Some of them are saved for you. So if you'll take a look at the question and answer screen, there's some good questions that you can get busy answering on now, if you don't mind. So.